a mother is from pregnant, childbirth, and post-delivery. That's after delivery. That's what it entails by maternal health.
Right.
Yeah.
So it's from childbirth or
It's from
pregnancy?
childbirth, and after delivery. That's what we call postpartum.
Right.
Yeah.
So it's a series that you need to do this at this time, do this at this time.
Yeah, it's a process.
Right.
Yes.
Of course, quite a process indeed that you're talking about here, Bwana Rodgers. And speaking about maternal health, somebody will be keen to ask also, why is it even important for us to be concerned about our maternal health?
Yeah, as your father, our mothers are the one who are building the nation by bringing newborns. The newborns are the one who grows and become the adult, and the process continues. Now we are concerned about maternal health because we don't want to lose that mother and that baby. Both of them we want them.
Right.
Right. Yeah.
So there is need for us to be keen and concerned about health, maternal health here.
Yeah, we should be very keen. Very keen.
Right. And looking at the numbers that talks about the mother and child death during births, it's quite shocking. You as a professional in this field of maternal health, what comes into your mind by looking at the figures? You find globally we are still doing worse when it comes to reducing the number of mother and child deaths here?
The mortality, the maternal deaths, what it records that there are more mothers we are losing during delivery. That's something that can be avoided, managed, and all mothers should have safe delivery. Yeah, that we can, so that we can affect the maternal deaths. Yeah.
Right.
Even the neonatal deaths, we don't want them. Yeah.
Very true.
We want the mother and the baby.
Both
Both of them. We need.
Right.
Yeah.
Very true. And looking at the mortality rates that you're talking about here, Bwana Rodgers, in Kenya, how would you say we are doing? Are we doing better or things are even worse?
In Kenya, since the current government, they introduced what we call Rinda Mama program. The Rinda Mama program was introduced to ensure that we have zero maternal deaths.
Right.
So the government is really supporting the mothers to have safety during delivery and during the entire period from pregnancy, because they have set programs that they cater for churches of mothers until delivery, even if it's a cesarean delivery.
Right.
Yeah.
Is it workable, the Linda Mama program?
It's working 100%.
Do you see results?
Results are there. Yeah, it's working 100%.
So the numbers have reduced?
Currently, the numbers have reduced.
Right.
Yeah.
Of course. Quite a milestone as far as the Jubilee administration is concerned there, led by President Uhuru Kenyatta, for bringing on board the Linda Mama program that Mr. Rodgers is talking about here. Coming back to you, Bwana Rodgers,
yes.
Do you feel like there's enough education there to the mothers about how they can keep themselves safe and how they can improve their maternal health?
First, what mothers they can do when they are clearance, when a mother is clearance is pregnant, so she's expectant. We have programs of we call them antenatal visits.
Right.
Whereby less than 16 weeks, that's less than 4 months, a mother should have the first visit. And during this first visit, there are so many
Visit to where?
visits to the clinic. It's called antenatal clinic.
Right.
Clinics. Antenatal clinic. That's the first clinic where a mother should come to the health facility. And there's a series of events that is done on the first visit. Because on assessment that we call maternal screening, you can realize that this mother is at risk during childbirth.
Right.
So as the mother comes in the first visit, you have to carry out so many things.
Right.
Yeah.
Like?
First, you have to take the HP level, the hemoglobin level. Yani ile tunasema kiwango ya damu. Yes. To see whether is this mother anemic. Because you know, anemia in pregnancy is very dangerous.
Very true.
Then we test malaria in pregnancy. Malaria in pregnancy, we lose the mother and the baby both because malaria is very dangerous. Because most of the time when mother is having malaria in pregnancy and it's not treated, she will miscarry.
Right.
Yeah. Less than 26 weeks, she will miscarry. Again, during the first visit, we do nutrition assessment. What the mother feeds on, because we want the HB level to increase and the blood level to increase.
Right.
Yeah. Then we do the blood groups. We carry out what we call urinalysis. We see whether there's any infection. Mostly we also see whether there's proteins in urine. Those mothers with proteins in urine, during pregnancy it's very dangerous when it comes to the third and fourth position, even after delivery, it's very dangerous. So we carry out what we call urinalysis. Again, for Mombasa, it's an endemic zone. We do what we call IPT, sulfadoxine pyrimethamine prevention of malaria. Also, we give nets for free. It's given for free. So every mother should be pregnant mother, and even everybody should be sleep under treated insects, mosquitoes.
Yeah, very true. Right. From the first now, per time at which you're speaking about, maybe if a mother out there and she has discovered that she's pregnant and she needs to go and see a doctor, clinician, on how they can fix that. It's something that it's key here, especially specifically for mothers who are watching us out there. There is need for you on the very first incident that you find yourself to be pregnant. There is need for you to go and have that first week check up from a clinician or a professional, so that they can get to understand how they can do about your pregnancy there. Bwana Rodgers.
Yes.
Let's stay still with this view, the first visit.
Yes.
You've mentioned a point where it's clear the first visit can tell you maybe the mother can have some bit of complications during childbirth. Is it so?
Yes, it can tell you. Yeah.
Right. And you know, during a time at which maybe we have complications during time of birth after the 9 months, mostly you find women wondering what exactly did happen to me, and maybe I went through all this series of whatever you're talking about here. How key is this first visit when you're talking about reducing these complications?
The first visit is the key, because you refer according to the appropriate management for that case. Because we say when you screen it earlier, you diagnose it earlier,
right,
treatment becomes easy because it was discovered early enough.
Right.
So even if it's a mother, we say that he has high blood pressure and they have discovered in the first visit, you put on treatment.
Right.
It subsidizes, it goes down, and she delivers keen. Very well. It goes very well when you diagnose it very fast.
It should come
but
at
if it's late, mostly if we say like an incidence of high blood pressure, a mother is not diagnosed earlier.
Right.
He survives all the pregnancy with high blood pressure. Mostly that condition we call it preeclampsia. Because she has not delivered, and despite of having high blood pressure.
Right.
Now after delivery, she needs to go to ICU. Yeah, so it's very dangerous.
Right.
Yeah, because high blood pressure, eclampsia, management, it needs an ICU center. Yes.
Right. And now it's a period of how many weeks do we do the first visit?
Less than 60. The first visit, according to WHO and the MOH regulations and guidelines, it should be done at 16 weeks.
16 weeks?
Yes.
So after pregnancy, 16 weeks? 2 months?
4 months.
4 months?
Yes.
Is when you go for the...
For 16 weeks, that's 4 months.
If at all I skip it, if at all a woman skips the 16
Mostly
weeks?
they skip it and they come at even 30 weeks, so that's when you initiate it. And you do all those investigations because you don't want to overrule out that the mother is doing well, despite having come on the fourth pregnancy and the third visit. No. We have to do it. Even if she comes at the 39 weeks, your mother's delivered at 40 weeks, we have to do the first visit. You have to screen all of those so to assess the safety of the mother during the delivery.
Right.
Yeah.
Quite true. And how hard is the situation if at all a mother comes at, skips the first week and comes after a couple of weeks? How hard is the situation on your side, you as professionals who are dealing with maternal health?
Okay, in that case, when a mother comes at the late visit, and she has an issue to deal with, sometimes it becomes a challenge.
Right.
Yeah. So we advocate for every mother, because these clinics are paid for by Linda Mama. This mother should go as soon as they realize they are pregnant.
Right.
Because when sometimes you say 16 weeks, most of them cannot count properly and say this 16 weeks. So as soon as the mother realizes that she's pregnant, let her come to the clinic. We'll advise her and the schedule now, how should she be coming to the clinic.
Right.
Yes.
Very true. Quite some bit of thoughts here from my guest. Remember, it's quite something complex here when you're talking about bringing life into this world. It's not as easy as you think we are talking about here. It takes a lot. It talks about maybe looking into things so seriously and taking good care of yourself as a mother out there and making sure that you maintain your maternal health to be at that standard and quality that it's supposed to be, so that you can bring on board that baby healthy, and we also have you plus the baby healthy enough, as what Mr. Rodgers is talking about here. Now, after the first visit, what next?
We have now the subsequent visits. We have the second visit, 16 weeks to 24. You schedule a mother to come again to the clinic. You also assess whether, okay, the first clinic, the issue may have not come to be seen properly.
Right.
So when she comes to the second visit, during that visit, you interrogate with the mother, you examine her, you see how she's going. She can tell you. Most mothers will tell you, I'm experiencing this and this. So from there, you continue now with take care. Take care now continues. If you realize any problem, appropriate care should be taken.
Right. And during the second visit now, Bwana Rodgers here, do you want to tell me, like, it's just a matter of looking at how she's faring and monitoring a little bit? There's no amount of testing and what have you?
Sometimes you can repeat. If you see the first visit, she had an issue. She had a raw HB.
Right.
So you can redo it now, see whether has it gone high, is it constant, has it gone low. Then the appropriate management should be taken from there. Yeah, you advise the mother according to the findings you have found on her.
Very true.
Yeah.
Right. Now, before the mother, you know, I'm trying I'm using so much before I come as if I'm pregnant here. But of course, before the mother comes now for the second visit, maybe I'm done with the first visit. Do you give instructions like how she's supposed to go and work out at home, how to make sure that...
Yeah, you should advise her on how she should conduct herself. Like lifting heavy materials, we don't discourage.
16 weeks, it's okay now, it's not...
Okay, depending on the on state of the mother. Okay, we advise to avoid, maybe even if she wants to lift a 20 liters jerrycan, why can't she use 10? Yeah, that's manageable.
Right.
Yeah, avoid lifting heavy materials, nutritionally, to feed very well.
Now, supposing I'm working and the kind of work I'm doing, it takes a lot of strength and power. How do we go about that?
Now,
should I resign from my work?
It comes there, and we advise them to resign during the third trimester, so that she can have enough time to breastfeed. The 90 days given the maternity leave, to be in contact with the baby. So we want to encourage that mother to work until 40 weeks, until when she is now ready to deliver, so that she gets it. Not to resign and consume the 3 months during pregnancy, and after she has delivered, and she will lose that job.
Right.
Yeah.
Of course, I do understand now why most of the pregnant women prefer sleeping a lot.
Yeah, adequate sleep is also good.
Something that is good. What does it bring on board? The sleep now.
Sleep, sometimes to avoid that, we have minor complications in pregnancy, like nausea and vomiting. So adequate sleep, you also manage such a minor issues, by adequate rest.
Very true. Quite a lot we are discussing here concerning the maternal health. Remember, we'd love to hear what you have to say concerning this. Talk to us. The number is below your screen. You can share your comments as well via the social media platform concerning what you think, what is your experience going forward when we are talking about mother or rather maternal health. How is your experience? How did you go about it? If you're a mother out there, did you find any need for you to go to a clinic Pastor, maybe in 16 weeks, like whatever Mr. Rodgers is talking about here, share your comments. Of course, we'll be looking at them as we proceed. Now, Mr. Rodgers,
Yes.
what is the biggest problem that rather what do the women do that maybe shows you like some kind of ignorance to the instructions that you give?
Some women are very funny. You get that a mother is having high blood pressure. You give her medication.
Right.
Instead of continue with the medication until you request her to stop, she decides to not to take.
Right.
Yeah. That becomes very challenging when you're dealing with them. Also, another thing that brings a challenge is when they don't come to clinic in time. Yeah. You get a mother is 7 months pregnant, she has not started NC visits. And you know that we have only 4 visits.
Right.
Each should be scheduled at 4 weeks interval. And now when she comes at 7 months, how many visits will she attend? 2.
Right.
2. If there was a problem, will it be manageable in the 2 months if it's a serious problem? Absolutely, it cannot be.
Right.
But it becomes a challenge.
Right. Now, after the second visit, you're talking about 4, like you mentioned, there are 4. Now, after the second, when we are coming for the third one now, what are you looking at? The sex of the baby or what?
It's not easy to decide the size of the baby, but sometimes we can detect it is a big baby. Big babies in maternity we call them macrosomia.
At big?
Big babies are called macrosomia.
Big babies meaning they are big in
They are
terms
big,
of...
yeah.
Okay.
And those babies have so many risks.
Okay, big babies, how do you tell? By the size of the...
Well, first you can do a scan.
Right.
And when you examine the mother's abdomen, you realize that the fetal parts are prominent.
Right.
Yeah. Yani unasikia tu mtoto ako kila, yani hiyo tumbo mtoto ako kila ni mkubwa when you examine the abdomen.
Okay.
That's how you can determine. When you realize that this baby, you detect it, you screen now and determine that this baby is big, you determine to do a scan.
Right.
It will tell you how big is the baby. And when you have mothers with big babies, you advise them to deliver in a well-equipped hospital with a theater. Because mostly we end up delivering by other mode of delivery like CS. That's cesarean delivery.
Right.
Yeah.
You know, you are trying to scare me. You know, some of us, we have wives who are big, so...
The size of the mother does not determine the size of the baby.
Okay.
Yeah.
Oh, I understand. Now I see why my producer was once a big baby, but right now, maisha imemchapa. But of course, it's a story of another day.
Actually, when you have a big baby, it's risky. Because those babies, when you deliver them,
Right.
they mostly develop what we call hypoglycemia. And their sugar levels tend to go down very fast.
Okay.
Imagine, tell me you have delivered now, and the baby's sugars are going down. You are managing the mother, and the baby's sugars are going down. What are you going to do?
Right.
Yeah, that's why I'm requesting that those mothers, as you have screened the mother from NT clinic, you can know the appropriate management. This is a big baby, go to an institution with
Right.
an operating theater.
What about small babies now?
Small babies.
Is it okay?
Preterm babies. Okay, a number of factors may lead to a mother having a preterm baby. Najua preterm baby meaning she has a preterm labor, so that child not to grow up.
You know, you're using terms that maybe my viewer there may be wondering, preterm, what do we mean here?
Preterm, so the baby is born before 37 weeks.
Okay.
So sometimes others don't present with serious issues. Others come out and they are okay.
Right.
Now, those who are preterm, they have difficulties in breathing. So when you have a preterm baby, you take her to nursery. Those are the babies now go to nursery. Preterm babies, even the big babies go to nursery. And for big babies, you can manage within 24 hours and they discharge them. But now, preterm babies who are less than 2,500 grams, that's 2.5 kgs.
Right.
You take them to an NBU unit for observation until they get at least they can be able to breastfeed by themselves, then you can discharge them home.
Right. Quite a lot. So in the third visit now, there we are talking about looking at whether if it's a big baby or a small baby.
You can determine it in the fourth visit.
Fourth visit.
Yes.
So
third visit is the frequent visit, the regular test you do. You go to the maternal record of the mother and see whether the first visit did she have any issue. The second visit, did she have any issue? Has it been addressed? If it has not been addressed, what's the issue? Then that's what it's a continued care.
Right.
Yes. Yeah.
Very true. Now, whatever you're explaining here is from your medical side and the professional side. Do you feel like mothers also need to understand this, whatever you're explaining here? Because what I think is that just mothers go into a clinic just because they are pregnant. They just go there and they do not understand why am I going even.
Mostly we teach them. Yeah, mothers, if a mother has come to clinic, we get them sit down, we teach them on all the issues concerning their maternal health until delivery. We teach them from what they need to do until they deliver. Right. We teach them even they should have some fear. Because when labor starts, labor starts naturally. It can start during the night. Where will you get the means of reaching you to the facility where you can deliver safely? So it depends that we teach them even have everything in place so that when the time comes that the mother now she's in labor, just carry what she needs, she has everything, and just come to our facility.
Right.
Yes.
Very true. Quite some bit of thought there on how to improve our mental health. And now we want to discuss this, Bwana Rodgers, at home.
Yes.
Leave alone going to the clinics now. If I'm at home and let's say my wife is pregnant, of course she is. If I'm at home and let's say she's pregnant now, what is she supposed to do?
In terms of daily activities, she has to do some exercise again.
Right.
Yeah, but not heavy exercise. Yeah, not that exercise that she can manage. Right exercises like walking. Most mothers like washing. And when we advise them, like when they are washing, they should not bend their back because they are pregnant. Because most of the time they lay down their pockets and start, they should raise it.
Don't you think you're making them to be lazy in some kind of way?
You are avoiding low back pain. Yeah.
Okay.
If akifua akiwa ameinama hawezi lala usiku, utasikia anakwambia nasikia mgongo. Lakini akifua amesimama usiku mtalala vizuri. So it's so small issues that can be managed by themselves.
Right.
Yeah, hata atakuleta kwa clinic akwambie naumwa na mgongo, and you advise on what to do. Just only
I get
education.
that complaint quite often.
Yes.
Could that be the cause?
Yeah. You just observe what does she do,
right.
how heavy, what does she lift that is heavy. Yes. Then from there you realize that this is the problem. And also during pregnancy, the backbone, at least it bends. I can't straight.
What do you mean?
The backbone, hii mfuba
for the mother now,
akiwa na mimba ina si anaendanga hivi, so haikai, kuna hiyo calf hivi.
Okay.
So to manage that calf to avoid pain, it's very serious. So that's why you avoid heavy. Even if she is sitting, she puts a biro here.
Okay.
To cover that space so that when she sits like this, she is comfortable.
Okay.
Not sitting and she is like this. No, you put a biro here, then she sits like this.
Now, for we now men, yes, can we help our ladies to to improve their maternal health?
Yes.
Do we have a role to play?
Men have a bigger role to play, from psychological support. Unajua, even psychological support peke yake, you tell the mother that you will be okay. That's peke yake, it's a medicine. Yeah.
Right. So ours is to make sure that we talk to our mothers and
psychological support, financial support. Even you can assist her do some other daily activities. Yeah.
Right.
You can cook for her, for even you can cook for her during the night and tell her, today I've cooked for you. That's it's enough. She can see that companion now. We talk about now companion in maternal health.
Right.
Companion should be from when she's pregnant until delivery. You should accompany her during labor. Yeah.
But of course, it's quite quite a lot,
Yeah,
especially for the men when our wives are pregnant there. Na hii kitu Rodgers huwa nasikia kwamba she can wake up and say nataka supu ya magoti at the middle of the night. What is it?
Mostly the iron deficiency. Iron deficiency is managed well when she starts clinic. You get some hematinics for her. Hematinics are ferrous sulfate. Ferrous sulfate is iron sulfate, and folic acid. Folic acid mostly it assists in the growth of the baby. Right. Folic acid it avoids what we call spinal bifida. So when she starts clinic, unaonanga wanapewa tembe ngapi? Two. Zinakuwa two different colors, pink and red. The one for pink, it supports the growth of the backbone of the baby. Those mothers mostly don't take that children will have spinal bifida. The spine will not be straight. Right. Yeah. And those who take iron sulfate, that's supposed to.
They normally have so many surprises. I don't know, is there biologically, medically, how do we do that?
Obviously, we have rumors and misconceptions out there about it.
No, some are realistic. I've gone through some, you know.
We hear some say she can't go without feeding some certain foods. But exactly. Maybe during pregnancy, what happens mostly is iron deficiency. When iron deficiency is low, that's when she wants to eat this. It's just manageable, something that you can manage.
Right. So if there is a father out there, a gentleman out there whose wife is pregnant, and you said he has a role to play, making sure that he improves the wife's maternal health, what can you advise?
Every father should play a role to ensure that the pregnant mother feeds well. You work as much as possible to ensure that she's very comfortable during this pregnancy. Even stress itself, right? You can get a preterm. Yeah, if mother strains a lot psychologically, labor will come itself due to stress, and you will get a preterm. Preterm, my friend, to manage, it's very challenging. So you need all the support she needs, all the care she needs, from psychological, financial, social, economic. You have to cater for it. Yeah, you have to play a very big role.
Right.
Yeah.
Definitely. Yeah. Quite a lot is being done when we are talking about the improvement of maternal health. Here we are discussing the topic today concerns maternal health. We need to help our pregnant women out there who largely depend on us to improve on their maternal health. And that is the topic of discussion this morning. We want to take a short break. When we come back, Mr. Rodgers will be discussing what brings about issues about stillbirths, talk about miscarriage, and what have you, some of these problems that may arise when we when at childbirth, what exactly can bring on board and what needs to be done in making sure that such cases are done with completely. That is on our last segment of the show. Remember, we'd like to engage you, talk to us. We are taking a short break. We'll be coming back with much more. Don't go too far. Coming back to you, Bwana Rodgers. Now, let's say we are at birth stage. Before even we get to birth, at what point should a mother start saying, or rather counting, like in the next few days I might deliver?
Mostly after 36 weeks. Anytime from there, mother can deliver.
36 weeks?
36 weeks.
Do we have any sign like, can tell me tomorrow maybe?
Probably when a mother starts labor, we have so many signs that indicates that the mother is in labor. Those one you will be taught in clinic. There are so many signs that you will be taught. Yeah.
Right, but I know the labor which I know is that maybe the labor at which they scream and they give birth. But I need something that can show me like tomorrow I might. Do I have to see to hear any moves in my stomach for me to tell me maybe tomorrow it's the day?
From the 18th week, for those who are having pregnancy for the first time, we have what we call fetal movement.
Right.
Hapo ndio mtoto anaanza, unasikia mtoto ameanza kucheza from 18 weeks.
Okay.
And those who have had previous deliveries at 16 weeks, that's what we call quickening. And the baby has started doing movements. Now, when it comes to, so movements are there daily. And there is no even at one point that the baby should not be moving in the stomach. In that process now, when it becomes to 36 weeks and above, there are true signs of labor and false labor. We have false labor.
Right.
False labor is when you have raw abdominal veins that does not radiate to the back.
Okay.
And when you have true labor, we have so many parameters that we see.
So it's for you, the medical practitioners, to know.
Yeah,
this
it's
is
for
true,
me now. It's
not me, the mother.
Yeah, no.
I
It's
might,
me to determine.
I might say it's false and yet it's true.
Yes, so on my examination, I will tell you this false labor or and relax at home. Now, we have what we call a bishop score.
Right.
Bishop score is what we do that to determine whether this mother is, okay, we will determine first whether the mother is in true labor by observing so many signs.
Right.
For instance, she will be having painful, she will be experiencing a lot of pain in the abdomen, but not only the abdomen and the back, that radiates to the back. That abdomen, the raw abdomen and the back. Okay, you can have the breakage of the water. You can see some blood stain discharge that we call show. Yeah, and when you examine, you get that the presentation of the baby, it's good, the right's good. Those are what we do in clinics. Those are so many things. There are a sequence of events that you do to determine whether this mother is in true labor. Yeah, when she's now in true labor, we admit the mother.
Right.
Yeah.
Very true. Now, let's say now we've witnessed a couple of maternal diseases and complications that have risen as a result of giving birth. Maybe you can take us through some of them and what can bring on board, can cause these complications to happen.
As long as the population is high, the complications are high. Yeah, as the mothers are delivering in high numbers, the complications also are high. First, in Mombasa here, this is a Roland.
Right.
An endemic zone for malaria. The first challenge is malaria in pregnancy.
Right.
In like here in Mombasa. If it will not be managed during now in any gestation that it was discovered that in these visits, if it will not be treated, mostly, well, first of the complications we get malaria in pregnancy is a stillbirth, as you have said. The mother will be anemic. And anemia in pregnancy, I told you that we have to check the HB level. When the level of blood is low, that's very serious. It needs an immediate attention.
Right.
Unexplained headache.
Okay.
Persisted day and night. That's very dangerous in pregnancy.
Right.
That also is also associated with the high blood pressure. When a mother is having high blood pressure in pregnancy, we call it a eclampsia. That also needs an emergency care. Also, infections. Infections can be urinary tract infection.
Right.
Or we can have vaginal candidiasis. Untreated UTI, stillbirth. Mother can miscarry because due to untreated UTIs. Yeah. And also UTI, it's very common if the mother will not observe hygiene during the time she's pregnant, because when she's pregnant, the bladder is pressed by the baby, so she has to go and empty the bladder frequently. If she will not observe the hygiene of the latrine she's using, if she's a pit latrine, the Chinese pot wanakalia, if she will not observe hygiene, she's at risk of getting a UTI. Yeah, and that's one, if the UTI persists repeating now and again, in raw gestation, she can miscarry.
Right.
Yeah.
Of course. So largely...
that's during pregnancy.
Right.
Oh, also kuna breeding. If a mother experiences a sudden vaginal bleeding before she's term, we call it antepartum hemorrhage. That's a PH. That's also a maternal complication, and it needs to be addressed immediately.
Right.
Yeah.
So you talking about miscarriage, you know, we need to start from there. We've witnessed a series of mothers saying that they've undergone miscarriage. We've also had our celebrities that have undergone a miscarriage. It's quite a situation health-wise when you're talking about this. You know, for that mother out there to understand what are some of the risks that can lead to a miscarriage, you know.
Miscarriage? Over-the-counter medication?
Right.
Yeah. Over-the-counter medication you can also, because when a mother she's pregnant and she is sick, we advise to go to a health facility and not to over-the-counter.
Right.
That can lead to a miscarriage. Also, we have rhesus incompatibility. But this one is manageable if a mother. That's why I told you when she comes for the first visit, we do what we call grouping and cross-matching.
Right.
We determine the blood group of the mother. So we are interested with the blood group and the rhesus factor. If, for example, you are rhesus negative, you are a blood group, let's check your blood group, you are blood group A, rhesus negative.
Right.
And your wife is rhesus positive. So we have rhesus incompatibility. The rhesus are not compatible. Because if you are to be rhesus positive and the mother to be rhesus positive, that's okay. When one is negative, rhesus negative means kuna proteins you lack in the blood group. So that's why yours is negative, hers is positive.
Right.
So if it will not be, for the first pregnancy, mostly it survives. Subsequent pregnancies, if you will not have received an anti-D medication.
Right.
That's an injection given at 28 weeks and 32 weeks sometimes. It's quite expensive. For one dose, it goes up to 6,000.
Right.
If it will not be administered in the previous pregnancy, or if it was not administered at 28 weeks, those mothers who come to clinic late without the anti-D, so most of the time you get them miscarrying at 26 to 30 weeks. Yeah, they lose that pregnancy.
Right.
That's what called miscarriage. Also, malaria in pregnancy, miscarriage. Yeah, it also brings to miscarriage.
Very true.
Yeah.
Now, when we are talking about the miscarriage thing and how we need to balance between the two rhesus factors that you're talking about here due to lack of proteins, does it involve also the kind of diet and nutrition?
No, that it's in the gene, not
It's
in the
about
diet.
genes.
Yeah, about genes, not
And
diet.
how fixable it is?
The only thing you can do to manage it is you administer anti-D so that you enable the body not to detect that the fetus is negative. So that you get that injection, the body takes it normal. This is a normal thing.
Right.
Because it's the body that will reject this a foreign thing and you miscarry.
Right. And can that happen at time of birth? Without, maybe it can
That's
persist?
during pregnancy. That's the process during
It
pregnancy.
can't get to the birth period at exact point of birth?
She can deliver safely if the body did not detect that this is a foreign thing.
No, I'm asking you because I know of someone who had some kind of that complication that you're talking about, the positive rhesus and the negative rhesus. But of course she delivered, but the baby died after a couple of weeks, if not two.
Neonatal death also has its own issues. Yeah, when you have delivered safely, maybe there was another issue. Yeah, because what happens, you miscarry, but after you deliver, the rhesus incompatibility ends there.
Right.
It does not come to the neonate.
It does not come to the
neonate.
Right.
No.
Very true. Right. And so, in a nutshell, for us to make sure that we at least be concerned and we need to look into these issues about giving stillbirths and miscarriage, what do I have to do as a mother, generally?
Stillbirth simply means that the baby died during delivery. Yeah.
Right.
Miscarriage, it means that the baby was born in less than 24 weeks.
Right.
There's a very big difference. The stillbirth is a baby who dies during delivery. And there are a number of factors. For instance,
Right.
We have what we call precipitate labor. We have two types of labor. True labor, we have precipitate labor. This is labor when a mother starts to give birth. It comes once.
Right.
We have a process. She has to labor, even normal labor goes for 18 hours. So when a mother labors for 30 minutes, that's a great risk for a stillbirth.
Right.
Yeah. So stillbirths happen during labor.
Right.
And we have a number of factors. Maybe the midwife was delayed to conduct the second stage of labor. We have first stage, second stage, and third stage. So during the second stage, if the midwife or the health care provider was during the service was not keen enough, you can get a stillbirth. Yeah.
Very true.
Yeah. Stillbirth happens during labor.
Right. Now, let's come to, there's this point of maybe we give, women give our birth to babies who have some bit of complications, like the likes of cerebral palsy kids. How do we go about that? What is, does it begin at the time of conception all the way through the process?
Cerebral palsy is sugars that affect the brain. So it's after delivery.
After
We have neonatal complications. There are so many. We have like the cerebral palsy. We have taribes. Those people who have feet haisimami vizuri. There are so many neonatal complications.
Right.
So this comes after, not during childbirth, after.
Very true. Now, let's talk about a little bit about concerning postnatal now. What does the mother need to do immediately after birth?
Postnatal simply means a period after delivery, take care of the baby until she becomes 60, I think it's 60 months. Yeah.
Right.
After delivery,
Right.
after delivery, we have now, that's now where we have to take care of. Now we have two people take care of the baby and the mother. Postnatal care, it entails educating the mother from breastfeeding. It's called just maternal child health.
Right.
Maternal child health. You observe from delivery whether there is any other postpartum complications. After delivery, sometimes complications do occur.
Right.
Like for instance, the most common, and it's all right, it's about excessive breeding. When a mother breeds profusely after delivery, it can be caused by a number of factors. If after delivery now is when you observe, is this mother going to breed? Is this mother able to breastfeed? Also, when we had the first visit, we did what we call HIV test. Every mother should be tested and every partner should be tested. Now when it becomes to postpartum, that's postnatal. It's called postpartum. Postnatal is just that period in 24 hours. When now it becomes now to postnatal care, those mothers who are, it happens that those mothers who now are diagnosed with to be HIV positive, those who have been known positive, they have been positive for all that long.
Right.
Now we need to take care of the baby, also not to be positive. That's where we have now to take the antiretrovirals for the neonate. Mostly they get some syrup postnatal and they breastfeed it. You observe, you educate them until that baby is not positive.
Right.
Yes.
Very true.
Yeah.
So between now the time at which the conception thing occurs in the whole process and after birth, which one is more easier to maintain the maternal health here?
None is easy, nor none is difficult. we say that all goes well. Yeah, you manage them well, all goes well. Yeah.
Right. Very true.
Especially the postpartum one can be very tricky for those who have delivered for the first time. We call them the primogravidas. Those who have delivered for the first time, sometimes it becomes a challenge. When breastfeeding becomes a challenge. So you need to educate that mother, the position out, everything.
It's your work, you as a professional.
Yeah,
what?
it's it's my work. Yeah, to educate on how to breastfeed, all those, it's me to do it.
Right.
Yeah.
And do you think there is also need for all the women, mothers, to also try and talk to their young girls on how they can do this stuff?
Yeah, they are experienced mothers also, they can guide their young ones to on how to take this process. It's a wrong process.
Right.
Yeah.
Very true. Now, let's talk a little bit about maybe these kind of ways of giving birth that people use maybe at home, and compared to the ones that they have to go into a clinic and meet a professional a midwife who has the experience to do that. What do you make of maybe these kind of midwives that we have in our villages and locals?
I discourage them totally because we have had several incidences where mothers deliver at home and complicate. Now when she complicates and they decide, they have now that fear that she has delivered at home, if we go to the facility, they will complain about the issue. So that they start delay of coming to the facility. If the mother complicates, for example, let's say most common is bleeding. How can they control bleeding at home?
Right.
It's very challenging. So for my case, I don't agree with home delivers completely. Every mother should deliver in a healthy facility safely. Because let's say for an incident in health centers where we work, if a complication arises, in less than 15 minutes you are in cause general. Mother has been attended. If she needs to be transfused, she has been transfused and the mother is okay, the baby is okay. Take the incidents at home. What are you going to do? You lose that mother. Yeah, those are the other causes that leads to maternal death.
Right. Now, in the event that labor has come in the middle of the night.
In the fourth visit, we educated them in all those that they observe. True signs, false labor, true labor, and what to do. So that the mother experiences what you taught her, she will come to the facility. You examine and determine it is true labor, you admit. False labor, you advise according. And she goes back home.
Right. Of course, but somebody will put into question, our grandmothers, our mothers gave birth in the villages there. There were no this kind of medical thing you're talking about.
That was nature. By then, yeah, nature.
Right, so things have changed.
Maybe the distance between the homes and the facilities is very far. Sometimes you can deliver at home. That one, let's forget it, it's the past. Now we encourage every mother to deliver in a health center. In a healthcare facility. Where she can get all the services in it at the right time. So that I told you that we need the mother and we need the baby. We don't want to lose any. Yes.
Very true. Now, there doing some bit of research concerning this topic, there are mistakes that mothers do during the postnatal now. But, for instance, maybe she took care of herself and her maternal health at the time when she conceived all the way by giving birth. After which, she says now, since I have the child in my hands, I'm good to go. Is that the case, and how should we go about it?
Again, if we went all the journey through the clinic until we have now we have safe mother and the baby. We have them, both of them. Why should she not come again to the facility if she has a problem?
Right.
Yeah, we need that. If we have neonatal care and we have neonatal signs, that we teach the mother, danger signs that a mother should observe and immediately should come to the facility. We also teach them during the postnatal period.
Right.
Yeah. Also, in the postnatal care, again, this mother also, she needs also to pay another child in future.
Right.
We give her education on the family care, family planning care. Immunizations also, she gets immunization, nutritional counseling. How should she breastfeed the baby? How frequent? At what age should the baby given diet now? Yeah, it's a process.
Right.
Yes.
Quite a process.
Quite a process.
Very true. Right. Now, maybe now let's get a little bit to have a discussion as we finish. Somebody will be keen to ask, how hard is it as a gentleman, as a man, to be concerned about maternal health? Are you comfortable with it? Do you feel like maybe it's a good profession somebody can take up?
Maternal health care is a profession that everybody can take. You can take, it's a good one. You need to care for those mothers of ours. We need to care for those babies. And also, in a healthy nation,
Right.
health must come first. Yes.
Right. Any challenges that you're likely to face, you as a man, when you're dealing with maternal health here?
Challenges, always challenges are there. Challenges we never miss.
Right.
For example, most mothers don't cooperate. You instruct them to do, you have seen a need for, maybe say you have seen a need for a mother to do a scan. Maybe you have seen the baby is not trying in the right presentation.
Position. Right.
Quality presentation. Position is just position you can be right or left. But we have the presentation.
Right.
When you have discovered that the presentation is also not good, and other factors, there are other factors you may consider. Maybe she tells you she had conceived in January last year.
Right.
Until now, you can see the sense. She will tell you that she had conceived last year January and she has not delivered, and you can see the gestation is not big. So you can do a scan and determine the gestation. You can request her to do a scan. Most of them don't
cooperate.
They have some misconception about the scan. It will affect the baby. It has no harm whatsoever.
Right.
Yeah. They have some and they have some knowledge they have stick to that is not assisting them. So it becomes a challenge when you are educating them. Also, mostly we have also religion also is a challenge.
Right.
Muslim ladies don't want male midwives. Sometimes it becomes a challenge.
Right.
You are the only one. You are with the mother, and she doesn't need a male midwife. So what do you do?
Right.
It becomes a challenge.
Right.
Yeah.
And maybe kushinda pale maternity is not an issue to you. Kushinda hapo kwa maternity. I'm trying to imagine as a man, nashinda tu hapo na wamama, you know. It's not a big deal.
We are used to it. It's not. We are used to it.
Right.
We are used to it because once a mother delivers safely, just sit and relax with the mother and observe after post delivery. Is there any issue? No issue. That's okay.
In your experience, Bona Rodgers, have you ever felt happier in your line of duty anytime? What did you see that made you happy and contented with whatever you're doing? Is there a day that you woke up and say, since I did this, I felt like I felt something inside me?
For quite some time, you have to be happy when you work.
Right.
Yeah. When I started working in maternity, sometimes back in Thika, one of the nursing homes, I thought there's a need for those mothers to be assisted. In fact, those mothers were good. That's what made me to be a good midwife also.
Right.
They were in good numbers and all of them were cooperating. So I felt guilty that if I would not assist them, it would be my fault. So I started running slowly until I got used to it.
Right.
Yes.
So now you're good to go with it?
Yeah, I'm good to go with it.
Very true. Thank you so much.
Welcome.
Right. On that note, ladies and gentlemen, I do believe that you've understood how best you can improve your maternal health, beginning by the time of pregnancy, conceiving, all the way going through until the postnatal, whatever you have to do after birth. And of course, you've grabbed some bit of notes concerning how can you improve your maternal health. And of course, quite some bit of thoughts from my guest, Mr. Rodgers Obwogi, who is a community nurse. And you've not said if they want to find your services, where can they find you?
If they want to find me, I work in Bokore CDF. That's a health facility supported by the County of Mombasa. It's there in airport. Once you, on your way to airport, you divert from Tatu Mwisho huko, then you go to Bokore. It's just a walking distance, not far. from the end of the bus terminus, huko mwisho wa matatu.
Right.
Yes.
Now, how are the ladies and women cooperating on on that side? How are the numbers? Do we see babies coming out of the facility?
Actually, we don't charge anything. Yeah.
It's absolutely free.
It's a free. You come and go out with the baby. It's free. Mostly, I told you we are supported by Linda Mama program. It pays for everything, from clinic until delivery. Now immunizations are free. Also, the government has funded free maternal health. It's for free. So if you need our services, just come to Bokori CDF.
Right.
We are there 24 hours working. It's a very nice place to be. Competent people there. Mostly by each month we have some 50 to 60 deliveries. So each day a mother delivers there.
Right.
Day and night, 2, 3.
Very true.
So it's a very busy place. We support mothers there. They all go without any complaints. The services there is very good. So if any mother is expecting to deliver soon, we are welcome.
Right. Very true. Any mother who seeks to deliver, then you can find Mr. Rodgers at Bokolo CDF Hospital at around Airport Ward there, one of the few hospitals that we are having supported by the county government of Mombasa. And on that note, we want to bring a wrap the show this morning. Thank you so much for your time. Thank you for sitting. And of course, we do not take it for granted. Also, I extend my sincere gratitude to my cameraman, Mr. Sami Lubanga, and my producer, Bridget Omondi, together with my directors, the likes of Madam Josephine Nzuve on the other side. Thank you so much. Let's do this.